Bismillahirrahmanirrahim. Let's start our lecture on adrenal hyperplasias, which is a very high yield topic for your board exams. But before that, let me discuss few extra points regarding insulin, which we discussed in our previous lecture. So first of all, let me discuss the effects of insulin in a tabulated form. Since tabulated form is easy to memorize for some people, so insulin increases the glucose uptake in skeletal muscles, adipose tissue, and liver. Other than that, it encourages the glycogen synthesis, so it wants the glycogen to form, and it inhibits the breakdown of glycogen. So it is inhibiting the glycogenolysis. And similarly, it encourages the formation of all large molecules. So it encourages the formation of protein, and it discourages the breakdown of lipids. In other words, you can say it wants more lipids, more glycogen, more proteins, and all more large molecules. Then there's an effect where we found that insulin is a very thankless hormone, since although glucagon increases insulin, but still insulin decreases the secretion of glucagon. So this is the effect of insulin, and these effects of insulin leads to hyperglycemia, which presents as polyuria, polydipsia, lethargy, polyphagia, which means more hunger, more thirst, and more urine. All right, and then you can see that decreased lipolysis leads to more ketone bodies, which can lead to fruity odor in breath, or you can say ketosis, ketoacidosis, and these kind of effects. So these were the effects of insulin summarized in a table. Now let's have a look on the effect of sympathetic stimulation on insulin secretion. So basically, we have two sympathetic receptors which affect the insulin secretion. One are the beta 2 adrenergic receptors, which increases insulin secretion, and other is alpha 2 adrenergic receptor, which decreases insulin secretion. Both of the receptors are stimulated by sympathetic stimulation, but one of them is increasing and the other is decreasing. So what is the ultimate effect? So ultimately, sympathetic stimulation decreases insulin secretion, which means that the alpha 2 adrenergic effects are dominating. They are more than the beta 2 adrenergic effects. So in a sympathetic stimulation, there will be decreased insulin and increased blood glucose. But in a scenario, if there is sympathetic stimulation and we have given alpha blockers, then definitely there will be an increase in insulin. Now, other than that, we have already discussed that glucagon increases insulin, and as a result, insulin is a thankless, hormone. And then, since sympathetic stimulation ultimately decreases insulin, so parasympathetic stimulation should increase. So parasympathetic stimulation, which has the receptor muscarinic M3, it increases insulin secretion. Other than that, we have a glucagon-like peptide, which increases insulin secretion. We use this as a drug also to treat diabetes. We will discuss it in detail in pharmacology. And then we have the somatostatin, which decreases the insulin secretion. So you can have an overview of all the factors which increase or decrease the insulin secretion. All right. Now let me discuss another flow chart. Have a look on this flow chart in which we are discussing the glucose metabolism. And basically, the point is that we have to understand which step is being regulated by insulin. So in glycolysis or in glycogen breakdown, most of the steps are reversible and they are not the rate limiting steps. But the conversion of fructose 6 phosphate into fructose 1,6 bisphosphate, which is shown over here as C, this step is a rate limiting step, and this is really regulated by insulin and glucagon, right? So since insulin is there, so to increase the process, so you can see basically this diagram is a larger view of this step. So this step is elaborated in this diagram, and you can see that this conversion is promoted by insulin because fructose 6 phosphate is converted into fructose 2,6 bisphosphate by insulin, and this fructose 2,6 bisphosphate then ultimately stimulates the further conversion. So insulin is stimulating the breakdown of glucose, and that is something very common. I mean, it is easy to understand that breakdown of glucose will be stimulated by insulin, since insulin wants a lower level of glucose in the blood, and breakdown of glucose is inhibited by glucagon. But how are they stimulating or inhibiting? By promoting or decreasing the formation of fructose 2,6 bisphosphate. Basically, fructose 2,6 bisphosphate is kind of a second product. So if there is more fructose 2,6 bisphosphate, so it just simply orders that what are you doing? You must be producing 1,6 bisphosphate, but my quantities are increasing. If my quantities are increasing, this means that you are having plenty of substrate. So for God's sake, go on, convert it into fructose 1,6 bisphosphate. So with this basically motivates this conversion or motivates the breakdown of glucose. So this was a high yield point, that this step is being regulated by insulin and glucagon, and you never know what kind of MCQ you get. Maybe you're gonna get an option in which they will ask you that there's a patient of diabetes and they are the hormone deficient, and what is the process stimulated by the deficient hormone. So first of all, you must know that the deficient hormone is insulin, and the process stimulated by insulin is conversion of fructose 6 phosphate into fructose 2 6 bisphosphate. So you can have such an MCQ. That is why I had to discuss this mechanism of action with you. Now let us head toward our adrenal hyperplasias, which is a very high yield topic. I just mentioned it. It's a very high yield topic. So first, let's have a brief overview of how the hormones of adrenal cortex are being produced. So there are basically three hormones of adrenal cortex, which we have three layers of adrenal gland, which we spell as, or we memorize them as GFR. G is the zona glomerulosa, which produces the aldosterone, or you can say the mineralocorticoid. And then we have the zona fasciculata, which produces cortisol or glucocorticoid. And then we have zona reticularis, which produces the testosterone, or you can call it as androgens. Now, testosterone is further aromatized into estrogen or estrogen-like products, right? So this is aromatase. So the process is aromatization of testosterone leads to estrogen. And then we have the conversion into DHT, but I will discuss that afterwards. So since the productions of, or the hormones produced by adrenal cortex are steroid in nature, so they start from cholesterol, right? So cholesterol is converted into pregnenolone, then pregnenolone is converted into progesterone. And from here, we can go towards 11 deoxycorticosterone, going to corticosterone, and ultimately aldosterone. Or we can go to 17 alpha hydroxylase, which converts it into 17 hydroxyprogesterone, and then 11D cortisol and cortisol. You don't have to memorize all of these steps. I'll let you know which steps are more important for you. But first, I'm giving you an overview that this 17 hydroxyprogesterone is converted into androstenedione and then testosterone. So there is a single molecule which leads to formation of three kind of hormones, right? So there are three different pathways. Some of the steps are common, such as the conversion of cholesterol into pregnenolone is common in all of these pathways. And similarly, this action by 21 hydroxylase is common in the formation of aldosterone and cortisol. And similarly, the hormone 11 beta hydroxylase, this is also common in the formation of aldosterone and cortisol. And similarly, the presence of this 17 alpha hydroxylase, this 17 alpha hydroxylase is required for cortisol also, and it is required for testosterone also, right? So now we are going to discuss the deficiencies. Since the deficiencies are very important, what is going to happen is, now why do we call them as adrenal hyperplasias? So there will be a deficiency of one of these hormones, and deficiency of one hormone will lead to either decreased synthesis of one hormone or deficiency of one enzyme, such as the enzymes such as 21 hydroxylase, or the enzyme 11 beta hydroxylase, or the enzyme maybe 17 hydroxyprogesterone, sorry, 17 alpha hydroxylase. These are the enzymes. So deficiency of any one of these enzymes will lead to a deficiency in one or two hormones. So now let's have a look on this. If there is deficiency of 17 alpha hydroxylase, there will be decreased synthesis of cortisol, and there will be decreased synthesis of testosterone. Since 17 alpha hydroxylase is required for formation of both of these hormones. So in such a condition, you will have a patient with decreased testosterone, decreased cortisol, and increased aldosterone. And since aldosterone has a function of sodium resorption and potassium excretion, so there will be hypernatremia and hypokalemia, right? So these are going to be the conditions. And hypernatremia or increased aldosterone means increased blood pressure. So there will be hypertension. And since the adrenal cortex is producing excessive aldosterone, so this excessive production can lead to adrenal hyperplasia. So now let me show you the table. It's time you should have a look on this table. So this is the table basically in which we have three kind of deficiencies. 17 alpha hydroxylase can be deficient, 21 hydroxylase can be deficient, and 11 beta hydroxylase can be deficient. I just discussed the 7 alpha hydroxylase deficiency in which we saw that there is increased production of aldosterone, and you can see mineralocorticoid is increased, and this increased mineralocorticoid increase the sodium resorption, which will increase the blood pressure. And as I told you that aldosterone has a function of excreting potassium, that is why there is hypokalemia. And since there is a deficiency of 17 alpha hydroxylase, so there will be decreased sex hormones and decreased cortisol. Decreased sex hormone definitely means decreased androstenedione. So these are the details of 17 alpha hydroxylase. But you will get a scenario in which first you will understand that there is decreased testosterone or decreased sex hormone, because this is the only deficiency which decreases the sex hormone. Now, what is going to be the clinical presentation of decreased sex hormone? What are the basic functions of testosterone? It forms the male genitalia, right? It helps in the formation of the penis, the scrotum, the testes, these kind of things, the male genitalia basically. And then in females, it maybe has a role in development of secondary sexual characteristics. So you can have a male with atypical genitalia, which means that there will be a very small penis, or you can say there can be a very interesting scenario. I found a scenario in which they presented that there was for example, 1 year old girl, 1 year old girl with a blind vagina, and there were no secondary sexual characteristics and these kind of things. Now, this was phenotypically a girl, but genotypically it was a boy, and this was even mentioned in the scenario. So, if there is decreased testosterone, so you can have a boy which will be presented as a girl. I mean, the parents are going to say that have a look on my daughter, right? So this will be the atypical genitalia. And if it is a genetically so genotypically female, so she will present with lack of secondary sexual development. So these kind of symptoms will lead to the diagnosis of 17 alpha hydroxylase deficiency. Whenever you find an adrenal hyperplasia where there is decreased testosterone, there must be 17 alpha hydroxylase deficiency. But there's another thing also. There is another hormone called as 5-alpha reductase, and you can see 5-alpha reductase converts testosterone into dehydrotestosterone. Now, what is the difference between the functions of testosterone and dehydrotestosterone? Testosterone is involved in the internal developments, the descending of testes, the development of testes, and these kind of things. And dihydrotestosterone, I'm sorry, I was pronouncing it as dehydro. It's basically dihydro. Dihydrotestosterone is involved in the formation of external genitalia, the formation of penis, the formation of scrotum. So if there is 5-alpha reductase deficiency, there will be, maybe abnormal development of scrotum, or penis will not be well developed. You will have a scenario in which they will say that there are proper testes development, but these testes are not descended, or such kind of a condition. So you must understand that there is 5-alpha reductase deficiency, but still 17 alpha hydroxylase deficiency and 5-alpha reductase deficiency can become confusing for you. So usually they do tell you in scenario that the patient has normal levels of testosterone. So if you find a patient with undescended testes or any kind of these problems, a male with ambiguous genitalia, and they say that the testosterone level is normal, this means that there is 5-alpha reductase deficiency. And if they don't say testosterone level is normal, or they do say the testosterone level is low, this means it is 17-alpha hydroxylase deficiency. I hope I'm clear in this case. All right. Now the next deficiency is 21 hydroxylase deficiency. Now, why is it more important? Among all these three deficiencies, 21 hydroxylase is most common. 90% of adrenal hyperplasias are basically 21 hydroxylase deficiency. So this is the most high yield point. Since 90% of adrenal hyperplasias are 21 hydroxylase deficiency. Now I am going to discuss 21 hydroxylase and 11 beta hydroxylase simultaneously, since they have similar effects. Not in fact similar, they are differentiating factors, but yes, they do have a similarity. You can see the green one as 21 hydroxylase and yellow one as 11 beta hydroxylase. Now you must be wondering that in 21 hydroxylase deficiency or in 11 beta hydroxylase deficiency, in both of these situations, there will be decreased formation of cortisol and decreased formation of aldosterone. Since both of these enzymes are required for the formation of both of these hormones, so there must be a similar clinical presentation. But the difference is that in 11 beta hydroxylase deficiency, although aldosterone is not formed, but this 11 deoxycorticosterone also possess some mineralocorticoid activities. So one thing is for sure, either it is 21 hydroxylase deficiency, or it is 11 beta hydroxylase deficiency, or it is 17 hydroxylase deficiency. In all the situations, there will be deficiency of cortisol. So deficiency of cortisol remains constant. This is not going to help you in differentiating between all three deficiencies. This remains same. How are you going to differentiate is, if there is a deficiency of testosterone and abundant production of aldosterone, this is 17 hydroxylase deficiency. If there is decreased mineralocorticoid effect and decreased cortisol effect and increased testosterone, now definitely if we are discussing about these two abnormalities, in both of these abnormalities testosterone will be high, right? Testosterone remains high. So if the mineralocorticoid activity is also decreased, this means that 21 hydroxylase deficiency. And if mineralocorticoid activity is somehow being maintained, this means that it's 11 beta hydroxylase deficiency, because although aldosterone is not being produced, but a product is being produced which do have mineralocorticoid effects. This is how you're going to differentiate between 21 hydroxylase deficiency and 11 beta hydroxylase deficiency. Now, what you have to memorize is, first you have to differentiate between the deficiencies so that you may diagnose the problem, you may diagnose the deficiency, and then just memorize the step of that hormone. For instance, you have to memorize that 17 alpha hydroxylase is responsible for converting progesterone into 17 hydroxyprogesterone, or pregnenolone into 17 hydroxypregnenolone. And then you have to memorize that 21 hydroxylation is involved in progesterone into this and this into this, and similarly 11 beta hydroxylase involved in these conversions. So you have to at least memorize these 3 to 4 conversions, because you can have an MCQ in which they tell you the symptoms and they say that which of the following process is being inhibited. So although you may get to the diagnosis that there is, for example, 21 hydroxylase deficiency, but if you do not know the step which is basically regulated by this enzyme, so you may not answer that question properly. So this was a very high yield point I have discussed. All right. Now I told you the clinical presentation in which there is decreased testosterone, right? There may be a male who is presented as a female, or there may be a female with no secondary sexual characteristics. But what will be the clinical presentation of increased testosterone, which is the case in 21 hydroxylase and 11 beta hydroxylase? So in both these deficiencies, increased testosterone present as maybe a female which has an enlarged clitoris. Since you know the clitoris enlarges, it can form penis, but if she is genotypically female, so it will not be a complete penis, but still the increased testosterone will lead to clitoromegaly, and you can have a symptom such as partial fusion of labioscrotal folds. So although it was a labia, but it has a partial fusion, so this makes the genitalia ambiguous. All these symptoms are written as virilization, right? And what can be the symptoms of increased testosterone in a boy? Symptoms can be that a mother brought a boy of 4 years age, and the boy is having maybe too much of sweat, or he's having hair in the axilla and hair above the around the penis. So these pubic hairs and axillary hairs at the age of 4 or 5 is definitely something alarming. It's before puberty. So this means there is increased testosterone in this male boy, right? So this was all regarding the adrenal hyperplasia, which is a very high yield topic. Now let's have a look on cortisol. So we discussed 3 hormones over here: aldosterone, but we will discuss the details of aldosterone in renal module. Then we have the testosterone. We will discuss the details of testosterone in reproduction module. And cortisol is something which we are going to discuss in this video. So cortisol is a glucocorticoid. It increases the blood glucose level, it increases the appetite, and it is released by the zona fasciculata of your adrenal gland. But remember, one important clinical aspect regarding cortisol is that people do take them as steroids. I mean, you generally call them as steroids. There was a patient who was taking steroids for the development of muscles or these kind of things. So cortisol is basically taken as exogenous steroids also, since it also decreases the inflammation. So you can have a patient with conjunctivitis or such kind of issue and using topical cortisol, topical steroids. And so there are several other effects of cortisol, which is why they are used exogenously, right? We will discuss them when we discuss the Cushing syndrome and pathology also, since the excess of cortisol leads to Cushing syndrome. All right. So cortisol increases the blood pressure, it increases the blood glucose, it increases the appetite. Since it is increasing blood glucose, so they present it as increased insulin resistance. All right. And the blood glucose is increased by increasing the gluconeogenesis and increased proteolysis, and the steps which were, I mean, similar to glucagon, right? And then the fibroblast activity gets poor. The inflammation is decreased, the inflammatory responses are decreased, the bone formation is decreased. And since it is decreasing the inflammatory response, that is why we use them in inflammatory situations, right? And how is it decreasing the inflammatory response? By inhibiting the WBC adhesions, by inhibiting the production of leukotrienes, by inhibiting the eosinophils, the lymphopenia, and these kind of things. Also blocks the interleukin 2 production. Now these are the things which you have to, I mean, cram them, or you can have a look on them so that they may come into your mind when you're solving the MCQs, but they are not very, very high yield. The main high yield points were that it is used exogenously to treat inflammations and these kind of things. And the regulation of cortisol is very simple. Corticotrophin releasing hormone from the hypothalamus basically stimulates the ACTH from the pituitary, and this ACTH then stimulates the cortisol production in adrenal gland. You do know that adrenal gland is producing aldosterone, but aldosterone is regulated by the renin-angiotensin. Then we have seen that adrenal gland is producing cortisol, and this cortisol is regulated by ACTH. And remember that increased formation of ACTH leads to hyperpigmentation. It is a very important clinical point of view that increased ACTH release leads to hyperpigmentation. All right, and then there may be stress situations in which cortisol is increased. I mean, more cortisol is released in stress situations. So this was some these were some points regarding cortisol. I don't think they're very difficult for you, right? You see, it's written over here. Exogenous glucocorticoids can cause reactivation of TB and candidiasis. So we do use exogenous glucocorticoids, but they do have the side effects. So candidiasis, you can have a patient with a white substance present on the tongue or such symptoms in the vagina. All right. Now let's have a look on the appetite regulation. Although this will be discussed in detail in the GIT module, it must not be discussed over here. But since it is written, so let me discuss. Now ghrelin, GH. So it increases the growth hormone, and it increases, since the boy have to grow. So come on, he has to eat more food. So it stimulates the hunger. And how is it stimulating the hunger? It acts on the lateral area of hypothalamus, which is the hunger center. So the lateral area increases the appetite. So ghrelin increases the growth hormone, it increases the hunger. And when do you feel hungry? You feel hungry when you haven't eaten food, or you feel hungry when you are waking from a long time. So sleep deprivation and fasting and Prader-Willi syndrome, this leads to increased ghrelin production. Now, Prader-Willi syndrome leads to obesity. This is a syndrome in which the patient gets very fat since there is increased appetite and these kind of things. Leptin. Now, what is leptin? As the name indicates, it is basically released from adipose tissue. I don't know how the name is related. I'm sorry for that. All right. Now, it is produced by the adipose tissue, and since adipose tissue is more in obese people, so it must decrease the appetite. Since obese people have to increase less food. But you must be wondering that you have a friend who is, I mean, quite fat, has a high BMI, and he even has a great appetite. So what is leptin doing over there? So basically, obese people develop a resistance to leptin. Although leptin is being produced and leptin does have a function of decreasing appetite, but they develop a resistance to leptin. Despite having leptin, they still have an appetite. right? So leptin is basically responsible for decreasing your appetite. It is a satiety hormone, so it has a role in keeping you thin. And then it acts on the, and how, where is it acting? It acts on the ventromedial area of the hypothalamus. So if I draw a hypothalamus over here, we have discussed, this is, for instance, this is the hypothalamus. So the when medial areas are involved in the satiety, and the areas of the lateral areas are involved in appetite. So ghrelin is working on these lateral areas, and leptin is working in the ventromedial area. Just a very rough diagram just to make you memorize the areas where leptin and ghrelin are being working. Another important thing is that leptin is involved in gonadotropin releasing hormone secretion. Right now, this is an extra point. Leptin is involved in the formation of gonadotropin releasing hormone in the hypothalamus. So what basically happens is, if there is an athlete, or a very lean girl, because she's a model or this kind of thing, you'll have a scenario, she was a model, she's very weight conscious, and she has lost the fat and these kind of things, very less adipose tissue, and so she is facing amenorrhea. So maybe the menstrual cycle is disturbed because there is decreased formation of gonadotropin releasing hormone, and decreased formation of GnRH, gonadotropin releasing hormone, will lead to decreased FSH, decreased LH, and ultimately issues in the menstrual cycle. All right. All I hope that I will discuss this again when we discuss the pathology. And then endocannabinoids is basically, it works at two areas. It also increases the appetite, and exogenous cannabinoids cause munchies. This is not a very high yield point. Thank you very much. I hope you enjoyed the video.